I'm very pleased that we have Dr. Ann Lyren today, but before we start, I'm always remiss, and it's not a fun thing to talk about, but it's Sydney Marie Snyder, and this is her endowed lectureship. We've been giving this lectureship for almost about 10 years. She's a little girl, 7-year-old. In 2007, she was being treated for acute lymphoblastic leukemia. She was on experimental protocols, study protocols, which are very strict for inclusion and as we continue their treatment. Well, she had a medication error during her study period, and they had to pull her out of enrollment. She ultimately died, and perhaps we believe that we precipitated that because we had to take her off her experimental therapy. The father's a firefighter, the mother's a teacher. Of course, we let the family down, but one of their wishes was to give back their settlement to Children's National, to endow this lectureship, to spend the morning and the day thinking about their child and how we improve safety and quality. So I'd just like to take a moment to remember Sydney Marie Snyder and the other children that we don't live up to what we like to deliver. As we transition then, we're so pleased to have Dr. Ann Lyren today as our Sydney Marie Snyder Endowed Lecturer. She's the clinical leader of the Children's Hospital Solutions for Patient Safety. If you haven't heard about that at the end of this, in addition to Harry Potter, I have a feeling you're going to be learning about solutions for patient safety. It's probably one of the largest improvement networks in the world and highly successful. On Monday, Ann and Solutions for Patient Safety were presented with the Eisenberg Award from the Joint Commission and the National Quality Forum, which is really, it's like a career lifetime award, and this was given to Solutions for Patient Safety due to the work that they're doing. Ann is an Associate Professor of Pediatrics and Bioethics at Case Western Reserve University and a pediatrician at Rainbow Babies Children's Hospital, where she serves as a strategic advisor of the Quality and Safety Program. She received her bachelor's degree from Harvard, then spent a year as a Rotary Scholar at the University of Edinburgh in Scotland. She completed medical school, then at Case Western, residency at Rainbow Children's, and then moved into the pediatric ethics world. She attended the IHI improvement seminars, transitioned over to quality and safety, really was one of the first people in 2011, and I don't know if you're going to tell the story, where you were sitting in a hotel room of 11 hospitals in Ohio, and they had the bold idea to come together in a collaborative fashion to benchmark and lead outcomes. And I believe you're one of the youngest people in that room, and that's why you probably had to do all the work. And then 10 years later, they've built SPS into a massive CMS-funded collaborative. There are over 130 hospitals, and she serves as the clinical director, which is really the one who leads everything. I'm thrilled to have her. It took us about 2.5 years to get Ann here because she's busy, and we really enjoy her presentations and her commitment to children. I think it's a perfect person to remember, Sydney Marie Snyder. Ann?
Good morning. So this was a situation where I came up with the title of the talk before I wrote it. And, you know, you realize, like, the die is cast after you send it to the CME office, and you think, wait a second, how am I going to make this work? So I'm not going to make you declare if you don't know who Harry Potter is, haven't seen any of the movies, haven't read any of the books, but it might be just a tiny bit less fun for you if that's the case. So hopefully that isn't for too many people. So what I'm going to do over the next 45 minutes or so is talk about the Solutions for Patient Safety, a little bit about its history, its principles, also share the results that we've had to date, and some about the future that we anticipate, and hopefully provoke you to think about your role in safety and provide some context at the same time with respect to the story of Harry Potter. I want to, before I get started, recognize the contribution that Children's National has made to the network. One of the first hospitals to join the national network when it was formed, and really is a front runner. In fact, I was here yesterday because this hospital is really recognized as one of the very top of the over 130 children's hospitals in the network in terms of its performance and participation in the network. And so I know that I send a collective congratulations, but I also send it to each of you individually because you play a role in making it work, and I appreciate that. So by way of getting started, I do have a disclosure. It's actually not anything to do with CME. I've never actually been to the Hogwarts School of Wizardry and Witchcraft, but one thing that working in safety has taught me is that if you're going to kind of dream big and go boldly forward to things that really don't seem possible, you need to suspend your disbelief a little bit, and so that's what we're going to do. So the thing about this place that I observed yesterday is I think you guys are kind of almost there. It's your elevator system, you know? I've never seen anything like it, but it just reminded me of platform 9 3/4. Okay, so who we are in the Solutions for Patient Safety. We're actually at the moment 137 children's hospitals that represent 38 states and, importantly, the District of Columbia, as well as 3 Canadian provinces. And it's quite an impressive group of institutions that are working together and empowering and inspiring one another. And you see the real grit in the hospitals and the work that they do together and the kind of the boldness with which they move forward. It reminds me a little bit of Ginny Weasley when she was talking about growing up with the famously mischievous brothers of hers, Fred and George. She said, you sort of start thinking anything's possible if you've got enough nerve. And I think we have a lot of nerve to think that we can accomplish our mission, which is working together to totally eliminate serious harm that happens to children. Quite an audacious goal. It's all about zero. But we know that we're not going to get to zero in eliminating serious harm right away. So we have interval targets, and these are our current ones. By the end of this year, a 40% reduction in what we call HACs, or hospital-acquired conditions, a 20% reduction in 7-day readmissions, and a 50% reduction in our serious safety event rate. And then I'll talk more about this one too, a 25% reduction in days away, restricted or transferred, which might not be one that you're as familiar with. So Rahul talked a little bit about the history and how we scaled up. It did start with the 8 Ohio Children's Hospitals in some Holiday Inn room in the basement north of Columbus. And we together started working on surgical site infections and adverse drug events. And this was really a charge that came from the CEOs of the children's hospitals who I think were sick of working on Medicaid reform and wanted to take on something that was a little bit more obviously meaningful to frontline providers and patients. So then in 2012, because of a contract with the federal government, CMS, we were able to spread it to become a national network, and Children's National was one of the first hospitals that joined that work, and it's just kind of gone from there. As I said, we're 137 hospitals, and these are all of our logos, and whenever I show this slide, I see people like, scanning, where is it? So yes, Children's National is here represented. So we're a network of opportunities. The privileged chances we have to help and improve and save lives of children in our midst are really pretty phenomenal. When you think about our whole network together, we have 31,000 hospital beds. And just the categories of surgeries that we work on to try to eliminate surgical site infection, there are 200,000 surgical procedures. We have over 500,000 employees, and when you start thinking about the specific hospital-acquired conditions, there have been 1.5 million urinary catheter days, 2.5 million ventilator days, 11 million central line days, and 35 million patient days. So again, lots of opportunities. So we're teachers and learners, and I have the privilege of representing this work, but in truth, our leadership is very distributed and widespread. Between our clinical steering team and our hospital-acquired condition at the national level leaders, as well as subject matter experts and work group leaders, we have over 160 leaders currently leading this work. And there have been, I didn't even add up how many we've had over the years, certainly some who have had critical importance from this institution, Rahul and Elizabeth, but also Darren Klugman and David Stockwell and Lisa Scafidi and Marianne Hilliard and Rebecca Cady. So again, a lot of people who have participated and helped us move forward. And as for teachers, I couldn't even count all the people who have served as leaders of webinars and at learning sessions. We've had 11,000 people attend our High Reliability Organization Wednesday webinars, and we have 8,000 people in our hospital contact database from all different specialties and backgrounds. So how we work: Hogwarts has its fundamental textbook, and there are days when I think we should try to adopt this one, but so do we. But it's Managing the Unexpected, which is a very well-written, about 160-page textbook, or book rather, that describes high reliability organizations and the principles that underpin them. So many of you were introduced to the principles of high reliability organizations during your error prevention training when you started your work here. I'm going to flip through them quickly to try to refresh them for you, and as I do, you can think about your organization and yourself and the degree to which you think you are realizing those principles. So just as a reminder, high reliability organizations are organizations that, like healthcare, operate under a tremendous amount of stress and variability and uncertainty, but for some reason just don't seem to have the same error rate that we do. So examples that I've listed here: commercial aviation and forest firefighting, nuclear power and naval aviation. So I guess in a couple hours I'm going to get on a plane, and there are, it turns out, 54 million flight hours every year in commercial aviation. And the average annual mortality rate is 250. Okay. In healthcare, the annual average mortality rate is estimated to be 200,000 people. So if you think about it, if that happened in commercial aviation, no planes would be flying. The airports would close. There'd probably be congressional hearings and a presidential commission, and everything would just come to a stop until the problem was solved. So what can we learn from these organizations? What do they have in common? And that's part of what high reliability organization scholars have thought about. So the first principle is preoccupation with failure. So this is regarding very small, inconsequential, even kind of half events as a signal that something is wrong. So managers in this case really seek out these situations. They encourage bad news. People are rewarded if they bring forward concerns and problems and mistakes and errors and failures, because those errors can help expose critical system flaws that, if corrected, could potentially save someone's life. So it's kind of like this friend of Harry Potter. Anybody know who it is? Neville Longbottom, good friend, but he has a number of mishaps in Potter world. He transfers his own ears onto this cactus. He melts his friend's cauldron. He falls off his broomstick and breaks his wrist. But he's brave, and he's open to learning. And at the end of the story, he does indeed save someone's life. He saves Harry Potter's life. The next principle is sensitivity to operations. This is understanding that workloads are heavy, and smart people at the front line are really, they're trying to get it done. They've got a lot on their plate. Managers are constantly monitoring that workload and can obtain and deploy additional resources if necessary. And in my mind, there's a very important component to this one, that's respect. So optimal leaders who may be high up in the organizational chart really have a deep and authentic respect for the expertise and the opinions of others, and particularly those that are at the front line. And this guy, Sirius Black, who's the godfather of Harry, had this quote. He said, "If you want to know what a man's like, take a good look at how he treats his inferiors, not his equals." So this might be a little bit of a loose association, but I think you could change it, that if you want to know what an organization's like, take a good look at how the people at the front line are treated, how people who don't have direct reports are treated. The next principle is that things go wrong, and we must not oversimplify our interpretation when that happens. Oh, I'm sorry. Reluctance to simplify operations. It's easy to make really snap conclusions when something goes wrong and say, oh, you know, from a distance, I know what happened. It was such and such. But really, it's extremely complex as you'll find as you begin to dig in. And when you do make those kind of snap conclusions, you limit the learning that can happen, and therefore you don't maximize the possibility of averting a similar incident in the future. Human behavior is really, really complicated. What motivates us and what we do, and so is the impact and the reverberations of what we do. And we don't have a crystal ball. But the Hogwarts headmaster, Albus Dumbledore, appreciated this complexity of human behavior and talked a lot about it in the books and movies. The consequences of our actions are always so complicated, so diverse, that predicting the future is very difficult business indeed. Commitment to resilience. Resources in high reliability organizations are continually devoted to training and retraining people, and the organization has the ability to kind of redouble and bounce back when errors occur. This is kind of organizational toughness, even in the face of persistent negativity. And it was interesting when I was researching for this talk, you know, just Googling Harry Potter and resilience. It's amazing to me that people write their PhD thesis on Harry Potter, and and lots of other kind of erudite essays. But the thing that they seem to like to write about the most is Harry Potter's resilience. He was an orphan, but he faced seemingly endless adversity since his young childhood, including some fairly significant hassle from, who are these folks? The Dursleys. So this is his adoptive family who really, I mean, they make him live in a broom closet, and they treat him not just like an orphan, but an outcast. Deference to expertise, this is another kind of respect principle. It's understanding that in an effective team, that people bring unique knowledge and skills and experience that can be valuable. And mindfulness, bringing organizational attention to experiences in the present moment, not overreacting, not underreacting, whether that's a clinical decision or a strategic decision, having the right perspective. So when we think about how we're going to eliminate harm in healthcare, this is a chart that reflects how high reliability organizations think about that. So our error rate in healthcare is somewhere down in the 10 to the minus 2, 10 to the minus 3 range, so we're down at the bottom. So reliability with process bundles is a really pretty good place to start. So in the Solutions for Patient Safety, we have a number of processes that we're working on, and this is, the arrows have grown and grown over the years as we kind of add domains of harm that we're working on. But it's things like, I'll read a couple: adverse drug events, catheter-associated urinary tract infections, central line-associated bloodstream infections, pressure injuries, unplanned extubations. I mentioned a couple already, surgical site infection. And our goal is to develop evidence-based guidance for practitioners, what the process should look like if it's most likely to be designed for success. I wish it were as simple as waving a magic wand, but it's really not. The magic in our case has to come from hard work and a lot of data. So the way our network works is that each hospital submits data, and they submit it in two categories. One is process reliability data, and one is outcome data. So process reliability data is just the number of times the patient receives the complete prevention bundle over the number of opportunities, with the goal being like 80, 90%, which doesn't sound very high to someone like my mom. She's saying, why is 80% the goal? But when you figure that we're at 17% right now on some of these things, we would move in the right direction. And then outcome data is essentially the rate of harm. And then we use two methods of analysis to try to develop those evidence-based bundles. One is statistical process control, and that's when we can identify top performers, see what they do, then ask other hospitals to reach a reliable practice, similar reliable practices with a high degree of reliability, and we can bolster our evidence for the association between those practices and the outcomes that we want. But there are some cases where, you know, nobody's really doing that hot. There aren't best practices out there, and then we just have to do old-fashioned tests. What do people think are some good ideas, and how can we test those factors to try to identify practices that are associated with improved outcomes? So to date, we have released 8 prevention bundles, and actually there's a 9th one that we're going to release for unplanned extubations during our spring learning session this May. These things are a lot of work. It was a lot of work to develop them, but it's even more work to do them in your organization for every patient across all the units with a high degree of reliability. And I think that there are a lot of work, especially for the nursing staff. It falls very heavily onto their shoulders, for which I say genuinely that I'm sorry, and I wish we had a better way to do it, and we need to be creative and try to figure out how it is that we can make this work less complicated and less onerous, and still do the right thing. So at the moment, we don't have an alternative, so we just have to plow forward with it. The most important obligation we have in healthcare, right, is primum non nocere, right, first do no harm. So it's just about the most important thing we do in our work. So it's also important that we work on safety culture. We're ever cognizant that process improvement alone will always, always fail with contrary culture. And if our organizations are not oriented towards patient safety, it doesn't matter what the policy says or what process has been outlined. In the game of hospitalopoly, culture always trumps process every time. And if you don't believe it, look at one harm that happened in your hospital, and you'll see how that comes into play. So we have 7 domains. Many of these you're familiar with. You've already been exposed to: air prevention training and leadership methods, cause analysis, lessons learned, how we share things, patient and family engagement. I know there's a lot of work here around that, which is awesome. Disclosure, so errors happen. How do we talk to people about that? I know I wasn't trained in medical school how to have that very difficult conversation. And then employee staff safety, which I'm going to talk a little bit more about in a few minutes. You're familiar with this term, the serious safety events, kind of the worst of the worst of the harm that we cause. These are deviations in standard of care that we have to own. They lead to a very serious harm, and there is just like, as Rebecca, you said last night, you can't make this stuff up. Circumcising a baby whose parents didn't want to be circumcised. Operating on the wrong twin. Failing to recognize what, in retrospect, is bloody obvious deterioration in a patient who's post-op that leads to cardiovascular collapse. It happens here. It happens in every children's hospital. So there's a lot of work ahead of us, and we really have to address culture if we're gonna really get to the bottom of it. So I talk about this culture work. We've now had, I think this is another one that has a 3.5. So technically, I think there are 9 waves of this. I've got Children's Nationals in the little box all the way to the left. So one of the very early adopters of this work. And in my time here yesterday, I could feel that that safety culture really is part of the DNA of this organization. It takes a super long time. It takes years for that to happen. So congratulations for that. So just a little bit about our design. It kind of works from top left to lower right, identifying harms that happen, and then moving them into the pioneer phase where we ask volunteer hospitals to participate in identifying those best practices. And then once we do get that evidence-based bundle that we're comfortable with, goes into what we call the aviator phase, which means we ask all 137 hospitals to implement those practices for every single patient in their hospital. And then orbiting is when we've achieved some of our goals and we're trying to sustain the gains, which is tricky business, and explore is how we share outside of our network the results that we've achieved. So about those results, I'll show you this slide first. It's important, if we're going to be successful, that things actually move down that diagonally, as I like to call it, diagram. So this is just a depiction of how some of the hacks and work have kind of moved through that process. So on the top is 2015 and 2016. We took on Unplanned Excavations, co-led by Darren Klugman here from Children's National, and peripheral IV infiltrates, and we started working more concertedly on central line-associated bloodstream infections, or CLABSIs, that happen in the hem-onc population. And you can see that in the last couple of years, we've added a number of different domains of harm, and hopefully, again, keep pumping things out the other side as we make progress and achieve our goals. So this is just a bar chart of our hacks that everybody is participating in our network, and you can kind of see what our progress is to our interval targets. I have to say the readmissions one, the 20%, is never going to happen in pediatrics, but that was the goal that CMS applied to us. So even to have a 4% reduction actually represents a lot of kids. Venous thromboembolism is at 4%. That is another one that's very tricky. It's those of you who are familiar with it know that there's a couple different causes. In older adolescents, it looks more like the etiology and the pathophysiology relates more to adult clots that form, but littler kids in the NICU and younger kids, it's really about line-associated clots. You know, when you pull out the line and light clots, the clot come out. It's not a good thing. And you can see pressure injuries and surgical site infection. We've made some progress, and then we've actually exceeded our targets in urinary tract infections, adverse drug events, and falls. And then the carve-out for the one CLABSI, the central line-associated bloodstream infection, is just because the operational definition for that one changed at the beginning of 2015. So the system changed fundamentally, so it was hard to compare the results before to the results after. This is just some bar charts and run charts of the events. You can get a sense of kind of the year-over-year improvement. This is through November of last year. So again, it's kind of acronym soup, but some of them that you might not be familiar with. On the right side of the second row, peripheral IV infiltrates and extravasation. I think the other ones I've covered. You also get a sense of the ones that are the most common. In the top right, CLABSI, very difficult. Like the low-hanging fruit on that one's gone. We're having to come up with really different and innovative ways to try to solve that problem, and it continues to be a very big one. So we can estimate the harm prevented and the cost savings by following our original center line and estimating how many children would have been harmed if we had stayed at that center line. Sort of a rough estimate, but it's actually hard to capture what didn't happen in hospitals, so that's the best way that we can think of. So you can see here, the middle column is the number of children who have been potentially spared harm through our collective efforts. And then, not work that we've done, but work that others have done, have put a price tag on some of these so we can get a sense of the costs averted. And when you add it all up, it's close to $159 million that we've averted in costs. And this was, I think, through September, so 9,400 children spared harm. I wanted to show you our serious safety event rate chart. So this is our very first cohort. We call it our legacy cohort. Children's National was in this one. And this is serious safety event rate, which is expressed as a rolling 12-month average per 10,000 adjusted patient days. That we didn't make that up, that's by convention, and we've kind of continued to follow it. So you can see that this group from 2014 through December 2017, they've had a 58% reduction in serious safety events, which is a pretty darn, when you think about what serious safety events are, it's not you had to come back in the hospital to get a few more nebs for your bronchiolitis or whatever. These are very serious issues. And we worried that maybe this is because it was like the best and the brightest hospitals we're in this cohort, but what happens if we spread it to other hospitals that are joining that haven't been at this so long? So we have a goal cohort that is it's about 42 hospitals, and this is their serious safety event rate. You can see they actually started, you probably didn't notice the numbers, but they started much higher with their serious safety event rate, but they've actually had a 57% reduction in their serious safety events. So, you know, that's really pretty good news. in the grand scheme of things, and something that on our bad days we have to allow to be the wind in our sails. We've also analyzed the effect of participating in the culture work on hacks. So this is our adverse drug event control chart, and this is NCC MERP is just a standardized way to categorize the degree of harm that a child has. So I think level F is a child received a medication error and had harm that required them to either be hospitalized or had a prolonged hospitalization. So not, you know, got Tylenol instead of Motrin kind of thing. This was something, this is serious harm. And then I is death, so kind of everything in between. And you can see that we've had a couple drops in that golden colored center line over the years through our process improvement. But what's interesting is when you cohort the hospitals that have been working on the process improvement by whether or not they've done the culture work, you see something interesting. So the blue line here are hospitals that have had pretty complete implementation of the culture work. They actually started with a pretty high adverse drug event rate, but have had an 87% decrease in their rate. And then the red line are hospitals that have had, you know, they're doing the culture work, but they haven't been very successful in implementing it. And then the green line are hospitals that just did process improvement. They haven't done any culture work in their hospital, and they've had a 24% increase. So 61% of hospitals who improved their ADE rate after the culture training, and that compares to 9% of hospitals who didn't do the culture training at all. So we think there's a synergistic effect, again, between the culture and the process improvement. So what's ahead of us? I think there's a fair amount of danger ahead. I love this sign. I actually made my husband slow down so I could take it because it's on the New York State Thruway, and it just, like, I get real tense when I'm in that area. So you might say a fair amount of danger. You might say we have a mountain ahead of us. In Harry Potter world, you might say we have a mountain troll ahead of us. But regardless, our challenges are really formidable. While we should be very proud of our accomplishments and our impact, it would be really quite disingenuous to fail to highlight the harm that continues to happen in our hospitals. 453, this is the number between January 2011 and July 2017. This was the average number of children who were seriously harmed every month in our network. That's a lot per day. And I hate to do the math on 453 times that many years times that many months. It's like 30,000 kids harmed in our hospitals. Holy cow. That, you know, it really does give you pause. And there's a story behind every one of those, of course. This is Truck. He is 250-pound, 15-year-old high school mega football star, recruited by just about every top college football program. And one day, Truck complained to the team trainer that he just wasn't feeling that well. He felt like he was easily winded, and his trainer appropriately recommended that he get checked out. And so one thing led to another, and Truck had a chest x-ray that showed massive cardiomegaly. So to further evaluate his problem, his team decided that he needed a cardiac catheterization. And he actually suffered from pretty significant obstructive sleep apnea, they discovered. So they decided that they wanted to intubate him during the procedure so that they could safely sedate him. And then they wanted to keep him sedated overnight since the procedure was going to end late in the evening. So early in the morning, so there was a routine in this ICU to do x-rays for the placement of the tubes. And so they got the x-ray, and as he was being rolled to remove the x-ray plate, his endotracheal tube became dislodged. And his oxygen saturation plummeted, and he actually had a cardiac arrest. So the team performed CPR, but they were not able to reestablish a cardiac rhythm for 8 minutes. Fortunately, he was in the right place, and they cannulated him for ECMO, and that happened very efficiently. And the good news is that Truck actually did okay. The bad news is that these type of events are really not all that rare. Some units have rates as high as 7 to 8 unplanned extubations per 100 ventilator days. And what's worse, the likelihood that you'll have a significant complication if your tube becomes dislodged is up to 20% in children. So, and the significant event is defined as cardiovascular collapse, requiring chest compressions or epinephrine. We really have to find ways to prevent unplanned extubations in children. So when I hear stories like that, or I try to process, the 453 number or the 30,000 number, I sometimes wonder if we're going to find our way out. But you know what? SPS hospitals have really made a significant dent, and we don't have any choice but to buckle down and learn and grow and try and test and accept no other endpoint than the elimination of these kind of harms. We might have to spark our ingenuity quite a bit, like Harry and Ron did, to find a way out. And in some cases, we're already starting to do that. So on the unplanned extubations case, this is in, if you remember my diagonally chart, this is in the pioneer phase. So only hospitals with the will and capacity and interest are participating in testing factors to try to put a prevention bundle together for everybody else. So in this case, there are 50 volunteers. There's very strong leadership, this group, a very good design, promising factors, the data submission's high, and in the baseline, among participating hospitals only, so those 50 hospitals, there are 259 unplanned extubations every month. But you can see that that center line has dropped. That's a 17% drop through the work that this group has done. So that's 42 fewer unplanned extubations every single month. So I think that this is an example that shows that there's quite a bit of promise in our work. So I want to come to employee and staff safety. We talk a lot about, and I showed you kind of how CLABSI was really dominant on our Pareto chart because they're the highest patient harm. But if you actually put our real Pareto chart that includes an employee safety measure, days away, restricted, and transferred, this is what it looks like. And you can see what quickly becomes #1 on our Pareto chart. So again, maybe you haven't heard of the DART. It essentially means that an employee was injured to such a degree that she or he cannot come back to their job the next day. So it turns out that working in hospitals is more dangerous than working in coal mines and heavy industry. I'll give you an example and perspective on that. So this is our current DART chart for our network. There are 55 hospitals that are reporting to this so far. Just in those 55 hospitals, there are 192 employees harmed every month. We just recently established a baseline for this work. And I think that those 192 people, it obviously matters, but I think there's an argument to be made that it matters for all of us and also patient safety. So this is, maybe this looks familiar to some of you from college. This is Maslow's Hierarchy of Needs. It depicts the needs of human beings from the most fundamental at the bottom to the pinnacle of the triangle, which is self-actualization, or becoming the best that you can be in service to yourself and others. You have to build this triangle from the bottom, and so most fundamentally, you need oxygen and water and things like that. But look what's right above that, safety. You need to feel safe. So 75 years ago, Abraham Maslow recognized that if you're not feeling safe, you're not going to be in a position to care for others. So why would that be any different for the employees in our hospital that we ask to give their all in caring for children who are here? So this is just our key driver diagram of our work in employee safety. We have 3 focus areas that we're starting with: overexertion, patient behavioral events, and slips, trips, and falls. Overexertion is focused heavily on the nursing staff. This is moving beds and sleep chairs and twisting or moving patients, trying to keep them safe on their beds. And also environmental services, the trash and the linen. When I clean out my office of paper that I've had in there for years and I just throw it in the trash can, somebody has to pick that up. And that's got to be moved to a different place. Or I put my full coffee cup that I didn't drink in the trash can. There's a hole in the bottom of the plastic, and it leaks all the way down
fall. I mean, somebody is dealing with that. So overexertion is something that we're working on, thinking about things like safe patient lifting tactics, equipment, addressing some ergonomic issues, again, especially with trash and linen management. Patient behavioral events, this is increasingly a problem in our hospitals. These are patients who, you know, kick, bite, spit, claw at their caregivers. We have a really twisted culture, martyr culture in our hospitals, where we think in part that's just part of our job, and sometimes people even show like, yeah, you know, badge of honor where I was bit by such and such patient, and we've got to reverse that, and it's going to be a lot of work. We need to start thinking about universal precautions for patients. We need to have better tools to anticipate and mitigate risks and manage escalations, behavioral escalations when they occur. And then slips, trips, and falls. The 2009 Bureau of Labor Statistics data says that the number of DARTs for slips, trips, and falls in hospitals is 90% higher than all other industries combined. And we are constantly falling in hospitals. We fall on drips from sippy cups and blood and urine and water and drinking fountains, so wet things. We fall when it's dry. We trip over cords and tubings and curbs, and we walk while we're talking and looking at our cell phones. We run into poles and get concussions and break our noses and all kinds of things. So really, there are just a tremendous number of hazards, a lot of low-hanging fruit here. We wear high heels with little studs and leather bottoms, and you know, again, we trip over our own feet sometimes. But there's still a lot of opportunity for us to improve. So I just wanted to talk a little bit about some of the work that's on the horizon for us. One of the new hacks that we're going to be taking on that hospitals are, again, in that volunteer phase of participating, is nephrotoxic acute kidney injury. And this is you know, kind of one that I think when I was doing my training, we really thought very little about. But we have now literature and evidence to support greater attention to the cocktail of medications that we give to children, and the vigilance for the effects that has on them, not only acutely, but also burgeoning evidence that having acute kidney injury can have long-term consequences on their health. Ventilator-associated events is sort of the new age VAP. We're letting go of VAP and taking on VAE. It actually turns out that they both have to do with ventilators and they both have to do with kids, but otherwise they're very, very different. So this is a CDC definition that we're still learning about, and there's lots to come with that. Antimicrobial stewardship, which is an important area, obviously, for reasons that I don't need to explain to this group. Employee staff safety, which I've already covered. Our pressure injuries work, and you might not remember, but that line chart will show that we had decrease in our pressure injuries as we increased our surveillance. It's kind of plateaued, and as we've investigated that further, we're appreciating that device-related pressure injuries are a real problem, you know, masks and ID hubs and things like that. So we're starting to we have a group that's working on device-related pressure injuries that happen. Thinking about health equity and trying to minimize disparities in our work, we're examining race, ethnicity, and language data via a survey to kind of understand the association between those factors and safety. We're testing improvements for central line-related venous thromboembolism. I think I mentioned that earlier, that's a real problem in children, and there's nobody that's got it all figured out. So we're going to have to try to work together to test some solutions and see if we can come up with some strategies. We have a surgical site infection bundle. We've actually, I think it's like 46% reduction. It's been great results. We're at 95% reliability with that bundle across our network, which tells me we've got about as much bang for our buck with that particular bundle. We need to come up with, but we're not done with surgical site infections. They're still happening, which means that we're going to have to explore some other options. And we've been talking with NISQIP, who has an outstanding, you may know, database to see how we can partner together and work in synergy to try to reduce these types of harms more. Human factors is sort of the idea of their engineers who are trained and skillful in thinking about how it is that we actually just take the human error out of it by making it impossible to do the wrong thing. You can't plug that. You can't plug the feeds into the IV. You know, it's a different kind of attachment. It's been amazing to hear of stories where humans have sort of overcome those things with duct tape and things like that. But at any rate, we think there are a lot of opportunities for human factors in our work. And then we're totally revamping our research, publications, and innovations. We have a tremendous amount of data that needs thoughtful people to look at it and learn from and publish and share the work that we've kind of done together. And then innovation is really, I mentioned the device-related pressure injuries. I mean, there's not something that you can buy right now that works. We need to make it, especially for children and babies. And then also other areas like I was mentioning ergonomics for trash and linen. You know, like I heard the other day about one of the big things is just, you know, the environmental services workers kind of leaning over all the time, especially when they go to dump the trash into the dumpsters, and they're designed different ways. But there's one hospital that's designed this spring-loaded platform so that the platform is always in the kind of ergonomic sweet spot for moving it, but it kind of comes up, and you know, things like that are really important innovations that we have to pay attention to. Just if you're not familiar with this concept, I wanted to introduce the idea of safety 2, which is actually a complementary approach to patient safety that we've traditionally thought of with those principles of preoccupation with failure, et cetera. And it makes a lot of sense to me. At its essence, safety 2 is about identifying and analyzing and emphasizing success. So in this model, humans aren't the weak link, they're actually the critical resource. It's thinking about why things go right. So, you know, we just delivered quadruplets. Like, and everything went fine. You know what? But nothing went purely as expected. So that required human beings to be, you know, to play a part and make decisions. And what's that all about? And how can we study high-performing units? I'm sure in your hospital you have units that are just, I mean, everything's running like wonderfully. Their error rates are low, their engagement is high. What's that all about? So it's really about digging into successes. And this, again, I don't think we're going to be throwing out focus on failure. I think we're going to need to do that too, and there's opportunities for us to learn from failure. But perhaps there's just as much that we could learn from studying when everything goes right. And we're going to spend some time learning about this together. This is a very burgeoning field, very theoretical right now. This actually originated largely in Europe. They're thinking a lot about this. There's not a lot of practical application, but it's starting, so that's exciting. So this is very hard work. We've had a lot of success, but I hope I've impressed on you that there's still a lot to do. I don't think anybody who's taking an honest look at his or her hospital is like wallowing in hubris. It's really quite the contrary. It's easy to get down, but as high reliability organizations, if we're going to model them, how do we stay resilient and rally and respond? How do we respond to get ourselves back on track? And I wish there were a potion or a hex or a twirl of the magic wand that would fix all our problems, but there isn't. And so we struggle when errors happen and ask ourselves, what does a good response to that look like? I don't actually like the notion of bouncing back when errors happen. You know, I think about Sydney's family. You know, when those parents lost that child, they're not going to bounce back. Their whole world changed. There are scars every time that there's an error like this. When an organization experiences a serious safety event, it's not going to be the same either. Fortunately, to be resilient, you don't have to go back in time. What happens to us becomes part of us, And our errors and shortcomings and adversities can become integrated in what we do in such a way that changes the trajectory in a positive direction. Some organizations are made stronger by adversity and some are capsized. And resilience is sort of the difference between those two scenarios. So the first step in resilience is taking responsibility for who you are and the results of your actions. And I think about something my mom often said, and your mom probably did too in so many words, that you're not responsible for all the things that happen to you, but you're responsible for how you respond when they do. So how do you respond when you have a serious safety event, when you're involved in a serious safety event? How does your organization respond when your CLABSI rate goes up? Or you find out that your reliability to a prevention bundle isn't what you want it to be? Using those disappointments to create opportunities is what resilience is all about. As Dumbledore said, scars can come in handy. I have one myself above my left knee that's a perfect map of the London Underground. And another piece of Dumbledore wisdom that's relevant to our work, we are only as strong as we are united and as weak as we are divided. So Rahul mentioned that on Monday, our collective work was recognized with the Eisenberg Award for Patient Safety. And I think part of the reason that we got that award because nobody would have thought 10 years ago that 137 children's hospitals would collaborate on anything, much less like harm that happens, which I feel like over half the world doesn't even acknowledge at all or know about at all. So we're really changing the model for healthcare, not only for pediatrics, but all of medicine. And you personally, and I mean you personally, are part of that and a really critical part of that. So what does the next level of collaboration look like and what are the limits? And one of the tenets of our network is that we will not compete on safety kind of between hospitals. And I used to be really proud when I heard someone affirm that, and I still am. I think it's cool, but how can we work together in even better ways? So I'm one of 7 kids. I grew up in this little teeny tiny town in Ohio, and it's sort of ironic because a whole bunch of my siblings live overseas, and I have like a bajillion nieces and nephews. I'm actually not even sure of the number at the moment. They live in Hong Kong, Bangkok, Tokyo, and then they live in Philadelphia and LA and Columbus and this little tiny town that I grew up in. And when they get sick, they won't come to me. They can't come to me. They're going to the children's hospital nearest them. So in this way, mine are yours and yours are mine. And I think that we cannot let harm happen to children in our midst, and we can't let our employees be endangered. So challenge me to improve. Set the bar very high. Set your expectations of me high and be completely uncomfortable with the status quo. Wonder why it is only safety that we don't compete on. Are we really going to compete on quality? If the fastest way to improve the lives of children is to work together, why would we let any competition get in our way? I'm really in awe of the possibilities of what we can do if we allow ourselves to work together. And it makes me think again about what Ginny said. You sort of start thinking anything's possible if you've got enough nerve. And one day we'll achieve our mission and no child will be seriously harmed, and that'll be just like catching the golden snitch. Thank you very much.
Thank you, Anne. That's great. I've gotten probably through like the 3rd video of Harry Potter, so I don't read books.
Yeah, okay.
So thank you for that.
Yeah.
We have about maybe 3-4 minutes for questions, comments for the group. I saw Billy. There's Billy, and there's the strong NICU team. Can you talk a little bit about unplanned extubations? I think success doesn't happen by accident, and you said there's some hospitals that have rates of 7 to 8 per 100, and I know what our rate is, and I'll let you tell that story, Billy, but I think it's important when we talk about safety, too, about successful examples. Could you be so kind to summarize in 1 minute all the great work?
In one sentence. Sorry, I have a cold, but this is phenomenal work. We're actually about to publish our paper that is showing our unintended extubation over 10 years that it took us to get where we are today, which is an extremely low rate. Dr. Saguier's in the Middle East, or I'd have her doing this because she's our medical director. But we started this 10 years ago as a collaborative between all 3 ICUs. So there was a kind of component of let's work together, come up with criteria, come up with measurements. And the biggest thing we had to overcome was we weren't really collecting the number of unintended extubations, which was much higher once we started having the proper tools to find it. We needed RT, nursing, physicians, all on board. To the point it was kind of taken into all the ICUs and became, I think that created the culture, because as you may rotate from one to the other, that same platform is there. It's taken the last step to really pull a whole team together, and I have to say nursing RT are huge in this, and they've created bundles, they've created teaching tools, they've created a risk tool we use every day at the bedside, the risk for unintended extubation, and have driven it down to 0.3 per 100. So I think, and you have to watch it. It'll go right back up again, just like you're saying. The culture is here, but then we have to continually talk about it. We present it at our care delivery meetings, which are multidisciplinary meetings every other week, and that data is presented plus CLABSI plus all of these. So if we start bouncing up, then people get nervous. So it's working together to do it. It's a huge endeavor, and like I said, it's taken us 10 years to get it down this low. So.
Well, a couple things that stand out to me in what you said. One is your units working together. I can't tell you how many hospitals that I visit where, I mean, the NICU and the PICU might as well be on different planets. I mean, they're not collaborating. So it's awesome that you have that, because not only do your trainees move, but the patients actually sometimes, they used to be a NICU patient, now they're a PICU patient. So that's awesome. The other thing that I would say is, this was, I think, unplanned extubations in the NICU was an area that people said for many years, that's the way it goes. Listen, their tracheas are millimeters long. We're not going to be able, this is just kind of the way it's going to be. And so I really admire your tenacity to that, saying, maybe that's not the case. Maybe we can actually drive these down, and with our practices and our culture, it sounds like. So congratulations.
Yeah, I think that for CLABSI even, it was the biggest thing to get people to say it's not a rite of passage to have an infection, that's not acceptable. Same thing with unintended extubation, and showing how many kids were harmed when that happened, how many actually did code, really opens your eyes. So anyway.
And Billy, I'll save the punchline for you, and we can end with this. So what is our rate?
0.3 per 100.
Yeah, so that's almost 25x. 25 times better than some other places. And thank you so much for coming and inspiring us and the great work you do.